you after a short break of summarization?
Relatively long period break.
So, recently in February 2025, from the SECH, they revised the last update of 2021 on chronic coronary syndrome. They changes the class of recommendation as well as the level of evidence. And this whole guideline is based on the trial and different studies. So it is not possible to cover the 60-70 slide in detailed discussion within 30 minutes. I will quickly go through some of the key points which highlight. One by one we will cover and discuss all the details. These are the 2013, 14, 15, 16, 21 and 23 update of AH guidelines. So I just want to highlight this point, definition and classify, evaluation, pre-hospital, in-hospital, and then what are the different scenarios in acute coronary syndrome condition, and then how we manage and what are the ideal strategy we do apply, and what are the complications and what things we do and what we can refer. So basically we all know that acute coronary syndrome is it is atherosclerotic process, plaque formation, plaque erosion, plaque rupture, ultimately end up with the thrombosis. That is the inflammatory condition. So it will compromise the myocardium flow. So ischemia, it is transient ischemia, and the flow is pattern, then it is classified unstable angina. If it is long time of angina, long term compromise the coronary blood flow, then cardiac biomarker is elevation. Ischemia lead to myonecrosis. It is classified non-ST elevation MI, and it is a transmural infarction that we consider as a ST elevation MI. So other etiology apart from that is like dissection, spasm, and Takotsubo, vasospasm, and other entities. But mainly we focus on type 1 myocardial infarction, which is etiology mainly on the atherosclerosis. Other than type 1 is type 2, ischemia, the supply demand mismatch, type 3, type 4, and type 5. So these are the visual impression of, these are the non-ST-ACS, partial occluded thrombus, ST elevation, transmural infarction, ST elevation. These are the changes and cardiac biomarker. So these are the basics. So now what pre-hospital guideline basically from the US and European countries, they have system, they have trained personnel, they refer according to patient scenario. But in India, there is a referral system is different. There is basic facilities lacking at some place. So we are trying to just follow the guideline. So what if patient having pain came to we suspect as SCS, then there is emergency medical service is there, which evaluate, do the basic parameter, do the history, they give the ECG basic cardiogram, and then the main idea is to take ECG behind the symptom onset, patient present, and took a ECG within 10 minutes of first medical contact. So within 10 minutes of patient presenting, valid ECG, if it is showing that HT elevation, there is a straightforward refer to PCI capable hospital. If it is not conclusive or non-diagnostic, local to transfer to the emergency department, which having basic facility including cardiac biomarker, echocardiography, and then do serial ECG monitoring. So basically the sentence says that increase in 30 minutes delay and myocardium geocardi increase the 7.5% relative risk of death per year.
Serial ECG લખો એટલે કેટલા મિનિટ લેવાનું?
Sir, serial ECG they consider is 1 hour to 2 hours. First hour, 1 to 2 hours after baseline ECG. Initial in-hospital assessment of patient with confirmed or suspected SCS. So after detailed history and physical examination, we suspect as SCS, so ECG within 10 minutes or obtain cardiac biomarker. So if there is a step forward, as we discussed, ST elevation MI go for reperfusion therapy. It's not conclusive. Serial ECG, serial troponin, and then clinical decision pathway is to define risk. It will define upon the GRACE risk score, TING risk score, based on that intermediate, low risk or high risk, and we can decide whether invasive angiography will be performed or not.
હવે આ સ્ટેજ પરથી there are almost 15 to 20% patient આજે તમે કહો છો ને even the ECG doesn't show any changes. The history એટલી ક્લાસિકલ હોય ને you suspect any infarct જ છે. That has happened many times with me. અત્યારે પણ recently 15 days back I suspected કે આને infarct જ છે. ECG normal હતું. હવે કાર્ડિયક ટ્રોપોનિન તમે તું સ્ટ્રીપથી કરો તો પોઝિટિવ આવી જાય. હવે ઇકો કરો તો અહીંયા ઇકોનો રોલ આવે છે. તમે અહીંયા ઇકોનો રોલ ક્યાં છે? રિજિયનલ વોલ મોશન એપ્નોમાલિટી.
So basically they want to say in
here patient has 100% right mammary block leakage. Even though ECG was not absolutely normal, but history was so classical.
the troponin will not be elevated in the overall. But they say guidelines say high sensitivity troponin is
So if we see the hierarchy of the changes that occur in blood, in myocardium, in ECG, which comes first and which follows?
So first is perfusion mismatch.
Okay, so first is imaging જે generally possible નથી પણ આપણે લોકો ચેક કરી શકીએ એવી કઈ પેલી change આવે?
Echo would be the first.
Echo is the first thing, right? But unfortunately, echo is not there in the initial evaluation. તમારી જે decision making છે એમાં echo નથી પણ જેમ સરે કીધું બહુ બધી વાર એવું થશે ECG changes નહીં હોય પણ if you put a probe, you will definitely see regional wall motion. Ideally echo હોવો જોઈએ.
And either that happened many times. It is like, the patient history. Patient history ઉપરથી ખબર પડે ECG નું જે થવાનું એ થાય. પણ તમારી પાસે તો પેલી ઇમિડિયેટ પેલી કાર્ડિયક ટ્રોપોનિનની કીટ હોય તમે એ કરી લો અને છતાંય ના હોય તો ઇકો કરવાય અને ઇકોમાં જો નોર્મલ આવે દેન કે હવે એને ઓબ્ઝર્વ કરો સિરિયલ ECG લો અધરવાઇઝ યુ આર મિસિંગ ધેટ વિન્ડો પીસ. એટલે આ here this is something is lacking here is the echo evaluation.
Sometimes laboratorically, electrocardiographically evidence is not there. Clinically we are suspecting like arrhythmia, ongoing LV dysfunction, yeah, angina. Then they consider as the intermediate to high risk.
So પેલી etiology વાળી જે atherosclerosis વાળી સ્લાઇડ કરી હતી ને એનો ECG બહુ ઇન્ટરેસ્ટિંગ હતો. જો અનસ્ટેબલ એન્જાઇનાનો ECG છે એમાં રાઈટ આમાં જે ડિપ્રેશન છે ST ડિપ્રેશન એ અપસ્લોપિંગ છે કે ડાઉનસ્લોપિંગ?
These are the downsloping depression, more than 0.5, too contagious.
ડાઉનસ્લોપિંગ છે.
These are the horizontal.
એટલે ટુ પેલા પેટ છે ને ત્યાં સુધી કન્ટિન્યુઅસ નીચે ટચ થઈ ગયું છે તો ટેન્સી
This is flat.
ફ્લેટ ઓલમોસ્ટ ફ્લેટ
છે બાકી અપસ્લોપિંગ હોય ને તો એ જનરલી
જે
અંજાઇના
પોઈન્ટ આવે ને જે પોઈન્ટ થી સીધું અંદર જશે
Mainly it reflects
has to be downsloping or flat.
This horizontal.
હા હોરિઝોન્ટલ એટલે ફ્લેટ પણ અપસ્લોપિંગ ST લેશન તમે ઘણી બધી વાર ટ્રેડમિલમાં જોશો એ મોસ્ટલી એ જ હોય મોસ્ટલી અને which is not indicative of system એક ડિફરન્સિએશન પોઈન્ટ અને ઇકો ઓલવેઝ એટલે રિજિયોનલ વોલ મોશન એબ્નોર્માલિટીઝ પ્રિસીડ્સ ECG ચેન્જીસ આ એક પેલું તમારે ખાસ.
So these are the scores they develop for the risk stratification when patients come into hospital, out of hospital assessment and after in-hospital assessment. They consider according to their score, they will define as the intermediate risk, low risk or high risk. So basically they summarize as when patient come, put a history, do a vital, take a baseline ECG and then physical examination. If you are suspecting SES, then do ECG, don't do patient first medical contact with the ECG and less than 10 minutes. Obtain cardiac troponin ST elevation, there is a reperfusion therapy, straightforward go. Then ST elevation MI is not, then serial ECG and profile monitor. And clinical decision pathway to define the risk as we already discussed. So this slide suggests you what happened if patient out of hospital survive with cardiac arrest, did a CPR, and what is the role and what is the level of evidence and class of recommendation. They said that patient with cardiac arrest with ST elevation MI who have been resuscitated should preferably transfer to. So I will put this slide for easy understand. You can see that if patient awake with the presence of ST elevation MI, guidelines says this is a class 1 recommendation, do directly shift to cath lab or PCA capital hospital. If the patient's neurological status is comatose, presence of stimulation MI, so if neurologically the patient will like return of spontaneous activity or like there is a favorable prognosis, then we put them in class 1 primary PCA. If patient is comatose, there is no prognosis and neurological function is deteriorated, presence of ST elevation MI, it is a class 2B recommendation, reasonable after individual assessment. And patient is comatoid, no ST elevation MI, there is a harm to do invasive angiography. So after discussion this, there are some basic, as we all know that ST elevation MI, standard medical treatment, oxygen therapy for those patients who have SpO2 saturation is less than 90.
ફેવરેબલ પ્રોગ્નોસિસ પોઈન્ટ્સ ડિસ્ક્રાઇબ કરેલા છે આ પ્રેઝન્ટેશનમાં એ લોકોએ પેપરમાં કયા કયા પોઈન્ટ જોવાના એના ઉપરથી
Patient's consciousness level.
નહીં આ જે પ્રોગ્નોસ્ટિક ફીચર છે એવું કંઈ હશે
They don't
ડિટેલમાં
describe, they based on the trial they
નહીં નહીં એટલે આ પ્રોગ્નોસ્ટિક ફીચર જે લખ્યા છે એ આપણે આપણી રીતે બધા તું તારી રીતે જો મારી રીતે જો એવી રીતે છે કે કોઈ સ્પેસિફિક 5-7 પોઈન્ટ લખે
clinical decision.
ક્લિનિકલી જોવાનું ખાલી
Individual basis. So 10% of patients with ST elevation may transferred by emergency medical service as an outpatient cardiac arrest. Recently, last week, one of the young patient who came in emergency department out of hospital cardiac arrest survived and echo showing stern myocardium with pericardial fluid collection. First year and the witness of that. So I had three or four cases of septal rupture or cardiac perforation after the clinical MI extensive. So these are the oxygen therapy first and foremost step, and then analgesics. Analgesic reduce the pain, it doesn't decrease the ischemia symptom. But we should consider if systolic PP is permissible, then we can give the nitroglycerin, sublingual or IV or morphine or fentanyl. So the first step is to treatment is the antiplatelet step during the hospitalization. Class of recommendation is 1 in patient with SCS, loading dose of aspirin is mandatory to reduce the death of major adverse cardiovascular event. These are the dose, ST elevation or non-ST elevation. Loading dose is 162 to 325 milligram orally, followed non-antireported, followed by maintenance dose 75 mg. Clopidogrel as well as prasugrel ticagrelor. Clopidogrel is less potent as compared to prasugrel and ticagrelor, which is more potent, rapid onset of action. But sometimes profile of patient is like old age, bleeding tendency, altered creatinine status. According to the scenario, we choose that antiplatelet agent.
તમે કઈ એસ્પિરિન આપો છો
ત્યારે આપણે કે એસ્પિરિન એન્ટ્રિક કોટેડ સિવાયની કઈ બ્રાન્ડ અવેલેબલ છે
Brand
anything is it available here
we preferably use non-antireported.
which one brand and
Post-paid.
EcoScreen is entry coated
ઇકોસ્પ્રિન તો ઇન્ટરરિપોર્ટેડ છે પહેલા એ તો પહેલા તો ચાવી શકાય નહીં ચાવો તો એનું આખું મિકેનિઝમ જતું રહે એ પેટમાં જઈને આપો ત્યાં તો પેશન્ટ ઘણીવાર હતું નહોતું થઈ જાય
એટલે એનું એબ્સોર્પ્શન થાય પણ એ તો ડિલેડ એબ્સોર્પ્શન છે એટલે EcoScreen જો હોય તો એ તો એન્ટ્રી કોટેડ જ છે આપણે નોન એન્ટ્રી કોટેડ તો કઈ છે અત્યારે કોઈ છે available?
ડિસ્પ્રિન આપો છો ચાવવા માટે
Disprin.
It is not only Disprin, which is
I screen 20 milligram loading.
325 watt, yeah.
So summarization of that previous slide is if patient of ACS initial selection of P2Y12 oral inhibitor in percutaneous if patient underwent PCI, but whether it is ST elevation MI or non-ST elevation MI, aspirin plus ticagrelor or prasugrel, this is class 1. Clopidogrel we can use in that condition, which are prasugrel, ticagrelor is not available either or not tolerated. If patient undergoing CABG, they say continue aspirin with clopidogrel or ticagrelor, start P2Y12 inhibitor, then set post-operatively. If patient is not having plan with invasive angiography, then aspirin and ticagrelor class 1. Clopidogrel when ticagrelor is not available or cannot be tolerated. If patient already outside fibrinolysis or thrombolysis, give aspirin with clopidogrel. Basically, they say that ticagrelor or prasugrel are more potent. They prevent the stent thrombosis. If patient undergoing invasive and angioplasty, then preferably give prasugrel or ticagrelor to reduce stent thrombosis. Patient doesn't go for invasive angioplasty, then give like aspirin with clopidogrel.
એટલે આમાં ટીકાગ્રેલોર ને લોડિંગ ડોઝ કેટલા ટીકાગ્રેલોર ને પ્લેઝોગ્રેલ નું લોડિંગ ડોઝ
Prasugrel 60 mg followed by maintenance of 10 mg.
600. Prasugrel 600.
Prasugrel.
અને ટીકાગ્રેલ
Ticagrelor sir around 80.
180
Loading
એટલે 2 tablets 90
2 tablets per week. P2Y12 inhibitor. In patient with ACS, oral P2Y12 inhibitor should be administered addition to aspirin is the major adverse cardiovascular event. So make sure that patient doesn't have any past history of TIA or CV stroke. That is, make patient to contraindication to prasugrel will worsen. Age is one of the risk factors. Weight and previous history of bleeding, cerebral bleeding. Oral P2Y12 inhibitor. In hospital management in patient with ST elevation and ACS. In patient with ST elevation ACS undergoing PCR, prasugrel ticagrelor recommended reduce. This is the same thing that I discussed. Prasugrel ticagrelor is recommended reduce the major adverse cardiovascular event as well as stent thrombosis, which is a class 1 indication. These are the patient managed with primary PCI. Prasugrel ticagrelor should be administration same slide, and these are the intravenous P2Y12 inhibitor. So intravenous P2Y12 inhibitor is recommended as class 2B among patients with ACS undergoing PCI who receive P2Y12 inhibitor. Intravenous candelabra may be reasonably to reduce the procedural event rate. Sometimes if patient having culprit LED vessel and other vessel is complex like left main disease, and we planned patient is unstable hemodynamics, we planned for doing the CABG followed by primary PCI. At that condition, it was intravenous candelabra having the rapid onset action, short duration, and 1 to 2 hours it will exert its effect. Intravenous candelabra rapid and potent platelet inhibitory effect with restoration of platelet function within 1 hour of drug discontinuation. So make sure that analgesics should not be administered within it. It will decrease the absorption of P2Y12 inhibitor, and clopidogrel is pre-formed. It will pass through the liver and convert its active form, so it will delay its action. After P2Y12 inhibitor IV candelabra infusion, what we can switch over to oral, then clopidogrel we have given 600 mg loading immediate after discontinuation, candelabra, and then maintenance as well. Prasugrel is 16 mg and ticagrelor is 180. Intravenous GP2B3 inhibitor. So many of time primary angioplasty has been done, flow has been achieved, but some microthrombi, some spasm, it will lead to slow flow, no flow. In that condition it works. So ACS undergoing PCI with thrombus burden, heavily thrombus, no flow, slow flow. Intravenous GP2B3 inhibitor, tirofiban, improve the procedural success in infarct size. They say that routinely you cannot use because it will harm, and because of the tendency it will harm the patient. Parenteral anticoagulation, when PCI is not planned, so they say intravenous unfractionated, preferably over the only heparin or other form in non-ST ACS, and enoxaparin or fondaparin they recommend as alternative to unfractionated heparin. Fondaparin they usually say avoid because it will affect the catheter fibrosis during the PCI. So coronary revascularization, when we plan that patient with ACS undergoing revascularization, parenteral anticoagulation should be given. If patient have history of thrombolysis, pre and post, we continue as heparin, and during the PCI, 3 and 4 until 3 to 5 days. Maximum it says 8 days. If PCI is planned, then intravenous unfraction is quite useful to decrease the major adverse cardiovascular event and ischemia event. And bivalirudin is useful alternative to reduce the bleeding and mortality. And fondaparinux should not be used to support risk of catheter thrombosis in that point of view. These are the dosing. These are the parenteral anticoagulation. They said the anticoagulation therapy treated with hydrolytic therapy. If you are planning for imaging, yes, then continue parenteral anticoagulation maximum 8 days until revascularization has been achieved. If no, then enoxaparin, class 1, fondaparinux, you can use as alternative therapy. What about the lipid management? So mainly type 1 MI, plaque rupture, plaque erosion, atherosclerotic event, strictly target to put LDL below 70. Patient with ACS, start high intensity statin to reduce the risk of major adverse cardiovascular event. Patient with ACS already on statin, do LDL level fasting. If more than 70, use alternate non-statin lipid lowering agent, ezetimibe, PCSK9 inhibitor, competitive acid.
એટલે પહેલા વન છે એની અંદર હાઈ ઇન્ટેન્સિટી સ્ટેટિન ઇટ ઇઝ મોર ધેન 70 એઝિથિમિબ બી તમે એડ કરો
Then preferably high intensity statin. We start in
પહેલું
ACS.
છે regardless of LDL level.
Yes, that's okay.
ACS આવે એટલે high intensity આપી જ દેવાની.
આપી દેવાની પણ એની સાથે નીચે સેકન્ડ લખ્યું છે ને તમે ઇટ ઇઝ મોર ધેન 70 એડિંગ નોન સ્ટેટિન લિપિડ કરો
Those patients who are already on statin, maximum tolerable,
નોટ ટોલરેબલ
I mean, high statin ऊपर जो है already, जो 40 mg rosuvastatin लेता हो, any event लगता है
તો ફીલિંગ
Otherwise, in this category, patient we need to reassess 4 to 6 weeks after lipid profile, and then we.
So how reliable the lipid profile on event day or the next day after?
Usually in our setup we do the fasting lipid.
We do, but is it exact reflective of the actual values before an event or it is little different?
In
How?
previous lecture we told this sentence.
But how?
Said we don't
મેં સાંભળેલું છે મને એક્ઝેક્ટ ખ્યાલ નથી તને કંઈ ખ્યાલ હોય તો કે
So, at the time of event, the atherosclerosis and inflammation is going on. It will reflect false.
જોજે ટાઈમ મળે તો કહેજે
નથી એના વિશે થોડું બધું ડિસ્પ્યુટ તો છે
So, in patient with ACS having LDL 55 to 69 milligram decimeter, then it is class 2 indication. And in ACS, initiation of ezetimibe in combination with maximum tolerable statin and consider reduce the adverse cardiovascular event in class 2B. If patient statin intolerance having adverse effect, then we can use non-statin lipid lowering therapy. These are the slides showing hospitalization with ACS baseline lipid profile. Patient already on statin. Then class 1 recommendation is high intensity statin. You can use ezetimibe if LDL is not controlled. Reassess after 4 to 8 weeks after discharge or follow-up. Patient already on statin. These are the criteria. They can add on another non-statin therapy. If patient is intolerant, then we can use alternate like ezetimibe, NTC1L1, cholesterol inhibitor, evolocumab, valivocumab, PCSK9 inhibitor, NTCNAR, SNRI inhibitors, competitive acid. So they showing that competitive acid, ezetimibe, and PCSK9 having favorable prognosis in.
Have you ever used ezetimibe alone and check how much LDL it reduces?
Study saying it increase.
સ્ટડી આનું કે છે પણ મેં જેટલા યુઝ કર્યા છે એમાં 50% કરતાં વધારે કરે છે એટલે જસ્ટ એનેક્ડોટલ ડેટા
Having antiplatelet, anticoagulation, and lipid level control, then these are the basic for the patient who has compromised LV function, last hereditary ischemia, then fifth LV dysfunction, beta blocker therapy, and renin-angiotensin system inhibition. All patients without contraindication. Contraindication is like acute heart failure, low output state, bradycardia, vasospasm, bronchospasm, second degree or third degree AV block, which require pacemaker later on. We PR interval is more than 0.24 milliseconds. Early initiation within 24 hours until unless contraindication. Beta blocker having the study prove that it will have a mortality benefit. And high risk patient with ACS less than 40% ejection fraction, having history of diabetes and hypertension, anterior location stimulation MI, ACE inhibitor ARB indicated, which cardiac remote deprivation will cause the mortality decrease. And mineralocortical receptor agonist is indicated, is class 1 recommendation. And ACE inhibitor or ARB, those ACS patients who are not high risk, preserve protection, they could be the class 2 indication. So mainly we focus on this reperfusion strategy. When and how we deal with the ST elevation patient. Now, patient present with cardiogenic stroke or hemodynamically compromised with ongoing ACS, mainly transporter infarct. First option, class 1 recommendation, emergency revascularization of concrete vessel like PCI either or CABG, to indicate improved survival. No, then we ask the symptom onset history, less than 12 hours, more than 24 hours. Less than 10 hours, 12 hours, if facility is available to transfer, no, then perform hospital transfer required, no, then perform primary PCI with our goal is to first medical contact, door to balloon time is less than 90 minutes. If we are referring the patient to another PCI capable setup, then our goal is to door to balloon time is less than 120 minutes. Both are class 1 indication. If patient having more than 12 hours of angina of onset, 12 to 24 hours, it is still class 2A indication for primary PCI. If patient stable, patient hemodynamically okay, no ongoing arrhythmia, no NV dysfunction, with more than 24 hours, then consider as a class 3, no benefit. In this condition, class 2 is primary PCI reasonable to improve clinical outcome in this scenario. So according to time frame, less than 12 hours, go with the primary PCI capable hospital. If facility is there, do PCI, if not, go thrombolize and then refer to PCI. If 12 to 24 hours, there is a chances to salvage myocardium, do PCI in favor of clinical symptom in more than 24 hours. It is already patient dead. So in that condition, if this condition is undergoing, then you can
વડોદરામાં એક જ ક્રાઇટેરિયા ચાલે છે. જ્યારે પણ પેશન્ટ આવે ને બ્લોક હોય તો ભૂલી ના એટલે આ બધું ક્રાઇટેરિયા ઓન પેપર વડોદરામાં એક જ ક્રાઇટેરિયા છે. એ લેસ દેન 6 અવર હોય, 24 અવર કે મોર દેન 24 અવર હોય,
irrespective of patient's
એન્જિયોગ્રાફી કરીને બ્લોક
ટાઈમ કાણો છો એ બી ઇમ્પોર્ટન્ટ
વડોદરાના ક્રાઇટેરિયા શું છે? મા કાર્ડ છે, મેડિક્લેમ છે કે કેસ છે?
કયું ડોર તમે ગણો છો that is also important. Which door, starting from which door?
नहीं sir, in our Indian system it won't be possible to go to window period patient transfer to PCI capable hospital. Patient can already out of
તમારી ત્યાં ધારો કે પેશન્ટ આવે તો 90 મિનિટ્સ સવાલ જ નથી, એનાથી બી ઓછામાં તમે પહોંચી શકો છો, બરાબર છે? પણ it goes to somewhere other HCP's work and then you start calculating door to balloon.
many of patient who came with window period having anterior director NVF 30 on discharge they improve with NVF. Many patient can salvage. Primary PCI reperfusion at non-PCI capable hospital. If there is ST elevation MA present, directly fibrinolyze therapy should not be administered due to risk of hemorrhaging, stroke or nasal. They said that if patient doesn't have ST elevation MA, do not thrombolize them. If patient have ST elevation MI, if fibrinolytic is contraindication, just then refer to PCI capable hospital because it will adversely affect neurological status, bleeding. If contraindication to fibrinolysis is not, then assess the symptom onset less than 12 hours, more than 12 hours. If less than 12 hours, so if 120 minutes delay, more than 120 minutes time from first medical contact to primary PCI, then administer fibrinolytic is no, then refer in already 12 to 24 hours, refer to PCI capability, there is no need to thrombolyze after 12 hours onset of symptom.
એ કયું ફિબ્રોનાઇટિસ કહ્યું ટેનેક્ટોપ્લેસ કહ્યું છે કયું કહ્યું
Subthrombotic plays.
આમાં ટેનેક્ટોપ્લેસ જ શું હતી
They said that retaplase or verteplase is more superior than tenec. Easy to administer to single dose. Right. Urgent CABG surgery recommendation is class 2A level of evidence. Patient with
હવે આમાં લાલજી એવું કંઈક પરિસ્થિતિ હોય કે તમે એક મેઇન કેટલેબ સેન્ટરથી 100 કિલોમીટર દૂર છો, ક્લોઝેસ્ટ કેટલેબ 100 કિલોમીટર છે, રાઈટ? અને પેશન્ટ ક્લાસિકલ ચેસ્ટ પેઇન સાથે આવ્યું પણ ઇસીજીમાં અને ટ્રોપોનિનમાં કશું નથી પણ સારું ઇકો પોઝિટિવ છે, તો તમે થ્રોમ્બોલાઇઝ કરશો, રિફર કરશો કે સિરિયલ મોનિટર કરશો?
the thrombolyze we can do in view of not there is no ST elevation. There is pain, ischemia is there.
અને પછી આપણે પેશન્ટને એવું કહી દીધું કે ભાઈ આમાં અત્યારે તમારા ઇસીજી અને બ્લડ રિપોર્ટમાં નથી કશું, તો આપણે ઓબ્ઝર્વ કરીએ છીએ. હવે 4 કલાક પછી ટ્રોપોનિન પોઝિટિવ આવ્યું અને હવે પછી આપણે થ્રોમ્બોલિસિસ ચાલુ કર્યું અને ડ્યુરિંગ થ્રોમ્બોલિસિસ વીટીવીએફ થઈને પેશન્ટ અનફોર્ચ્યુનેટલી સાલ્વેજ ના થયું, તો
That is a class 1 indication.
સાલ્વેજ ના થયું, પેશન્ટ તો એક્સપર્ટ થઈ ગયું.
But echo suggestive ardent, then there is evidence of
તો પણ પહેલા તો હતું તો ત્યારે તો આપણે એક્શન ના લીધી, તમે તો ના પાડી થ્રોમ્બોલાઇઝ નહીં કરવા. સમજાણું શું પૂછ્યું?
I understand there is no transmural infarction. So they said that bleeding chance will until unless the patient transmural infarction or MI હોય.
ખાલી ઇકોના ફાઇન્ડિંગ પર થ્રોમ્બોલાઇઝ થાય કે નહીં, હા કે ના? પાછળથી પેશન્ટનો લોસ થઈ જાય તો જવાબદારી કોણ?
Sir, the guidelines
ગાઈડલાઈનની જવાબદારી
either invasive angiographical evidence of totally occluded vessel or either stimulation.
આ તમે બધું લીધું ને, આમાં કાંઈક મેન્શન હશે ઇકોનો. સાવ ઇકોનો શબ્દ જ ના આવે અત્યારે લગી તમે બાયપાસ લગી પહોંચી જાઓ એ તો જરા લેસ લાઈકલી છે. જોજો આખું પેપર વાંચજો જરા.
અને આવા કેવા કે જેમાં સ્ટેમી તમારું ફેલ થયું, પીસીઆઈ ફેલ થયું હોય અને પછી તમે એને સીએબીજી કરો તો સક્સેસ શું થાય?
Very patient-centric decision, like patient is deteriorating. If we are doing nothing, then we lose the patient. But if you attempt primary PCI, which is complicated or fail primary PCI, then another option is CABG surgery and preserve the myocardium as early as possible.
આપણે થયું છે એવું કંઈ એને સક્સેસ મળે છે?
Sometimes the stent thrombosis after the event, after PCI, we observe 2 to 3 times. Evening में प्लास्टिक करे तो नाइट में फरीથી સ્ટેમિંગ.
હવે મને એવી પરિસ્થિતિ સમજાવો ને કે આમાં શું લખ્યું છે? પેશન્ટ વિથ સ્ટેમી ઇન whom PCI is not feasible, એટલે ટેકનિકલ આસ્પેક્ટ આપણે જવા દઈએ, ઓર સક્સેસફુલ નથી, રાઈટ? વિથ લાર્જ એરિયા ઓફ માયોકાર્ડિયમ એટ રિસ્ક, મતલબ કે તમારો એમઆઈ તો થઈ ગયો છે પણ હજી પણ there is bigger risk, રાઈટ? તો તમે અર્જન્ટ સીએબીજી વિચારો.
તો અર્જન્ટ સીએબીજી
What is urgent CABG?
will be more stressful to the patient, more harmful.
What is urgent CABG?
Urgent CABG irrespective of patient's profile, irrespective of antiplatelet, directly open up.
એટલે કેટલા સમયગાળામાં ટાઈમ ડ્યુરેશન શું?
They didn't mention time duration, but if fail, then you consider as a CABG. It is class 2A.
Effective to improve clinical outcome.
CABG, every PCI capable hospital, they consider as a backup CABG.
એટલીસ્ટ આ પેલું યલો ને બ્લુ છે એટલે હું રિલેક્સ છું, બાકી તો તમે બોલો છો એમાં અત્યારે કંઈ ટ્રસ્ટ કરી શકાયું નથી, બરોબર? અર્જન્ટ CABG માટે આવી રીતે પેશન્ટ
Particularly left main માટેનું હશે અથવા તો
Totally occluded area from left main smoke patient.
બાયલના જ આ ટાઈપના પેશન્ટ જ્યારે CABG થઈ શકે એવા સેન્ટર પર પહોંચે ને ત્યારે દુનિયાભરની ડેમેજ તો થઈ જ ગયો, પછી સાલ્વેજ માટે કેટલું બચ્યું હોય that is always a question.
can be effective to improve clinical outcome.
એટલે એના માટે તમારે થેલિયમ સ્કેન ને પેલું પરફ્યુઝન સ્કેન કરવો પડે કે હવે આ આટલું બધું છે, આપણે 2-5 દિવસથી કંઈ કર્યું નથી, તો ઇઝ ધેર એનીથિંગ which we can actually salvage? બરાબર ને? હું ખોટો હોય તો કે
No,
લોજિક
no, it's surgeon's call.
સર્જન નો કોલ ક્યાં થયા? રિપરફ્યુઝન કોણ કરે? રિપરફ્યુઝન ઇમેજિંગ.
Restore, no.
Surgeon will always take a call of surgery.
There are chances of on-table arrest.
એ કદાચ હવામાં ના કરવાનું કારણ ના કરે.
That is patient-centric. They mainly
પેશન્ટ નું સેન્ટર કરતો નથી આગળ વધતા. નહીં એટલે આજે બાજુવાળા તો બે ટેબલ માં જ રિકવર થઈ ગયા. રિપરફ્યુઝન એટ નોટ પીસીઆઈ.
non-PCI capable hospital reperfusion strategy. In patient with ST elevation MI with estimated time first medical contact to device activation less than 120 minutes, or those with contraindication to fibrinolytic therapy transfer to PCI capable hospital for urgent primary PCI is recommended to reduce the adverse cardiovascular event. Class of recommendation 1. If patient with MI with symptom onset is less than 12 hours and primary PCI is more than 120, do fibrinolytic and then refer to PCI capable hospital. And this slide, this one. ST elevation MI treated with fibrinolytic therapy transferred to PCI capable center immediately after fibrinolytic therapy. Only fibrinolyze within 12 hours of symptom onset. If failed reperfusion, how can we say it is failed reperfusion? These are the clinical signs: patient having ongoing angina, persistent elevation of ST segment, less than 50% resolution in anterior lead or less than 70% in inferior lead, unstable or electrically or hemodynamically. Then immediately angiography will be performed with rescue PCI. If no, then early angiography in 2 to 24 over period of time.
સો persistent ECG એટલે કેટલા ટાઈમ સુધી persistent હોય પછી જાય તો એ ચાલે કે તમે થ્રોમ્બોલાઇસિસ ચાલુ કર્યું એટલે ઇમિડિયેટલી જતા રહેવા જોઈએ.
Not immediately, but it will take
What is the
6
duration?
hours.
6 hours. Okay.
Routine invasive versus selective invasive. In which patient need routinely we can do it, and which patient we choose as a selective according to risk score. These are the risk score. Very high risk patient, unstable patient, like any of these condition, immediately invasive within 2 hours. It's a class 1. These are for non-STSS. In ST elevation areas, there is a straightforward shifting together. In high risk non-STSS, like Grace risk score, ongoing STD changes, tropoid value is going routine invasive class 1, but less than 24 hours. If intermediate risk, then coronary angiography you can perform before hospital discharge, and lower risk category, routine invasive or selective patient, class 1. But if we are suspecting as a low risk, then do a non-invasive test, stress echo or like CT coronary angiography, and then coronary angiography will be performed before hospital discharge.
તો એ જે લાસ્ટ વાળું જે છે લોઅર રિસ્ક એમાં તો તમારે પેલું નહીં જોવાનું એક્સરસાઇઝ ટેસ્ટિંગ.
Yes, sir. We can do non-invasive first in low risk patient after
બાકી
patient.
મને વચાતું નથી એમાં લખ્યું છે ઉપરમાં કે એક્સરસાઇઝ ટેસ્ટિંગ કરો અને પછી આ કરો.
No, they mention the description. CT coronary angiography.
આ ઉપર જે ગ્રે અલાર્મ લઈને 5 વસ્તુ એ શું શું છે જરાક કહો તો.
Sir, low risk category, Grace risk score is less than 109. In 109 to 140 intermediate, more than 140 Grace score is high risk. TB risk score less than, absence of ischemic symptom, and tropa less than 99%, and no STD changes. Either ECG changes, cardiac biomarker, or either risk score, whether patient fit on low risk category or moderate.
Troponin less than 99 percentile of normal range or abnormal range? નોર્મલ રેન્જ થી લેસ ધેન 99 મતલબ બિલકુલ એલિવેટેડ નથી થયું.
They include high sensitivity troponin.
ઓકે વોટએવર સેન્સિટિવિટી ટ્રોપોનિન પણ બિલકુલ એલિવેટ નથી થયું એની વાત ચાલે છે.
Yes. Normal range of reference limit, less than 99%.
તો એ બધામાં રૂટીન ઇન્વેઝિવ કરવાનું.
They said that coronary angiography before hospital discharge is class 2 indication, and non-invasive risk stratification during hospitalization or recurrent symptom.
તો ઉપર ગ્રીનમાં લખ્યું છે રૂટીન ઇન્વેઝિવ.
This group of patient having do not symptom, do not ECG dynamic changes, no troponin elevation, everything is within low risk category. So first we can do some non-invasive test and then we decide for.
કેટલી સ્લાઇડ છે
Mainly આના ઉપર છે.
ના ના ટોટલ કેટલી સ્લાઇડ
Total 64.
અને હમણાં હવે કેટલી બાકી
સેકન્ડ પાર્ટ રાખીએ.
હા હમણાં ઓલરેડી 9:30 થઈ ગયું છે
9:30
એટલે તમારે દોડવું પડશે આટલી બધી સ્લાઇડ નેક્સ્ટ
Plus a complication અને cardiogenic shock અને
નેક્સ્ટ ટાઈમ રાખો
ઇમ્પોર્ટન્ટ તો છે જ આ બધી જ વસ્તુ ઇમ્પોર્ટન્ટ છે.
તો છે ને આવતા વેનસડે ના જ